This is Lecture 05, Shock, Sepsis, and Septic Shock. Shock is not a blood pressure. Shock is failure of oxygen delivery. Sepsis is not a lactate. Sepsis is life-threatening organ dysfunction from infection. In the emergency department, the job is to recognize hypoperfusion early, give antibiotics and source control without delay, resuscitate intelligently, and start norepinephrine when fluids are not enough. The objectives are these. First, classify shock by physiology and recognize the four-type framework. Second, use point-of-care ultrasound to evaluate undifferentiated shock. Third, recognize sepsis and septic shock using current Society of Critical Care Medicine criteria. Fourth, execute the Hour 1 sepsis bundle. Fifth, use the vasopressor sequence. Norepinephrine first, vasopressin second, epinephrine third, with stress dose steroids for refractory septic shock. Sixth, manage cardiogenic, obstructive, and hemorrhagic shock with the right therapy for the right physiology. And seventh, avoid the classic board traps: overfluiding, delayed pressors, lactate tunnel vision, missed source control, and misclassifying shock type. Shock is oxygen delivery failure. Blood pressure matters, but it is not the whole story. A patient can be normotensive and still be in shock if perfusion is failing. The ED mindset is to ask, is delivery failing, is demand rising, and is the patient getting worse despite initial treatment? Do not wait for hypotension to call shock. Shock falls into 4 physiologic categories, and the treatment for each is different. Hypovolemic shock is loss of intravascular volume from hemorrhage, severe dehydration, or third spacing. Treatment is volume replacement, ideally blood for hemorrhage. Distributive shock is loss of vascular tone from sepsis, anaphylaxis, neurogenic causes, or adrenal crisis. Treatment is fluids and vasopressors, with disease-specific therapy like epinephrine for anaphylaxis. Cardiogenic shock is pump failure from large myocardial infarction, severe valvular disease, or end-stage cardiomyopathy. Treatment is inotropes, reperfusion, and mechanical support when needed. Obstructive shock is mechanical obstruction to filling or output from massive pulmonary embolism, tamponade, or tension pneumothorax. Treatment is mechanical relief, thrombolysis or thrombectomy, pericardiocentesis, or needle decompression. The board trap is treating the wrong category, like flooding a cardiogenic shock patient with crystalloid, or anchoring on sepsis when the patient actually has tamponade. 2 ITE buzzwords lock the category. Warm shock with flushed skin and bounding pulses points to early distributive disease, classically sepsis or anaphylaxis. Cold shock with mottled, clamped down extremities points to cardiogenic disease or late, decompensated distributive shock. Neurogenic shock breaks the rule. It is the one distributive shock that runs with bradycardia and warm extremities, because sympathetic tone is lost above T6. This is the quick reference. Hypovolemic shock, blood for hemorrhage, balanced crystalloid for non-hemorrhagic loss, and source control of the bleed. Distributive septic shock, antibiotics, crystalloid, norepinephrine, source control, and steroids if refractory. Distributive anaphylaxis, intramuscular epinephrine, 0.3 to 0.5 milligrams, fluids, and an epinephrine infusion if persistent. Distributive neurogenic shock, fluids, and norepinephrine, with attention to bradycardia. Cardiogenic shock, cautious fluids, norepinephrine for hypotension, dobutamine for inotropic support, reperfusion for STEMI, and early cardiology and mechanical support discussion. Obstructive shock from massive PE, anticoagulation, systemic thrombolysis or catheter-directed therapy, and PERT level escalation. Tamponade, pericardiocentesis, tension pneumothorax, immediate needle decompression, and tube thoracostomy. The board principle is to identify the category, then deliver the category-specific therapy. When the shock category is not obvious, point-of-care ultrasound resolves the question fast. The RUSH exam stands for Rapid Ultrasound for Shock and Hypotension. It is organized as pump, tank, and pipes. The pump component assesses left ventricular function, right ventricular size and strain, and pericardial effusion or tamponade. A hyperdynamic left ventricle with a small chamber suggests distributive or hypovolemic shock. A poorly contracting left ventricle suggests cardiogenic shock. A dilated right ventricle with septal flattening suggests massive pulmonary embolism. The tank component assesses the inferior vena cava for filling status, lungs for B-lines or pneumothorax, abdomen for free fluid suggesting hemorrhage, and pleural spaces for effusion. The pipes component assesses the aorta for aneurysm or dissection, and the lower extremity veins for deep vein thrombosis when pulmonary embolism is suspected. The board concept is that bedside ultrasound shortcuts the differential and changes management within minutes. Sepsis recognition is clinical. The patient has suspected infection plus organ dysfunction. That may be hypotension, altered mental status, hypoxia, renal injury, coagulopathy, or lactate elevation. The qSOFA score can support your concern, but it does not replace clinical judgment. Lactate helps risk stratify, but lactate is not the disease. The disease is infection plus dysregulated physiology. The definitions matter because they map to treatment urgency. The qSOFA score is a bedside screen using 3 criteria: respiratory rate of 22 or greater, altered mental status, and systolic blood pressure of 100 or less. 2 of 3 suggests a higher risk patient who deserves closer evaluation. The qSOFA is a flag, not a diagnosis. Sepsis, by the Sepsis 3 definition, is life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock, by Sepsis 3, is sepsis with persistent hypotension requiring vasopressors to maintain a mean arterial pressure of 65 or greater, plus a serum lactate greater than 2 millimoles per liter despite adequate volume resuscitation. The board trap is using a negative qSOFA to rule out sepsis. A negative qSOFA does not exclude a septic patient. Memorize the 3 qSOFA cutoffs exactly. Respiratory rate 22 or greater, altered mental status, systolic blood pressure 100 or less. 2 of 3 is the high-risk threshold. Boards love to write a distractor with a respiratory rate of 21 or a systolic of 102 and dare you to call it positive. It is not. The Surviving Sepsis campaign, Hour 1 bundle, compresses the ED management into 5 actions. First, measure lactate and remeasure if the initial lactate is greater than 2. Second, obtain blood cultures before antibiotics, but only if it does not delay antibiotics. Third, administer broad-spectrum antibiotics within 1 hour of recognition for septic shock and within 3 hours for sepsis without shock. Fourth, begin rapid administration of 30 milliliters per kilogram of crystalloid for hypotension or a lactate of 4 or greater. Fifth, start vasopressors if the patient remains hypotensive during or after fluid resuscitation with a target mean arterial pressure of at least 65. The bundle is a structure, not a substitute for ongoing reassessment. Antibiotics are time-sensitive in septic shock, with a goal of administration within 1 hour of recognition. The empirical regimen depends on source, resistance risk, immune status, and the local antibiogram. For unknown source, common emergency department empirical choices include vancomycin combined with Zosyn or with cefepime. Add gram-negative double coverage in critically ill or immunocompromised patients. Add atypical coverage for severe community-acquired pneumonia. Consider antifungals for high-risk patients with appropriate clinical context. Cultures are useful, but they should not delay antibiotics in a crashing patient. In unstable sepsis, give broad coverage early, then narrow when data return. The most common septic shock source on boards is pulmonary, followed by genitourinary, then intra-abdominal. If the STEM hands you an elderly patient with no obvious source, default to chest and urine first. Fluids are first line, but they are not autopilot. Balanced crystalloid is the preferred initial fluid based on current evidence. The starting target is 30 milliliters per kilogram for sepsis-induced hypoperfusion or septic shock, completed within the first 3 hours. The better ED behavior is repeated reassessment. Check the lungs for B-lines, look at the heart and inferior vena cava, watch mentation, skin, mean arterial pressure, urine output, and work of breathing. Fluid responsiveness is not the same as fluid tolerance. Stop when the patient is no longer responsive or no longer tolerant and move to vasopressors. Norepinephrine is the septic shock workhorse. If the patient remains hypotensive after initial fluids, or if you know more fluids will harm them, start norepinephrine. A typical target mean arterial pressure is at least 65, individualized to the patient. Peripheral norepinephrine is acceptable short-term with a good proximal IV and close monitoring while definitive access is arranged. The classic distractor on the boards is dopamine as a first-line agent in septic shock. Do not pick it. Dopamine carries higher arrhythmia rates and no mortality benefit compared with norepinephrine. The vasopressor sequence in septic shock is predictable and board-tested. First line is norepinephrine, titrated to a mean arterial pressure of at least 65. If the patient remains hypotensive on rising doses of norepinephrine, the next step is vasopressin at a fixed dose of 0.03 to 0.04 units per minute. It is not titrated. It is added on at that fixed rate, and it is both pressure-sparing and additive. The third agent is epinephrine when shock remains refractory, particularly if there is cardiac dysfunction. Phenylephrine is a niche choice, useful when tachyarrhythmias limit norepinephrine, but it is not standard first line. Dopamine is not preferred in septic shock because of increased arrhythmia and worse outcomes compared with norepinephrine. The board pattern is norepinephrine, then vasopressin, then epinephrine. Stress dose steroids are indicated in septic shock that is refractory to fluids and norepinephrine. The trigger to memorize is refractory shock on 2 Pressors. That is when hydrocortisone 200 milligrams per day intravenously goes in, given as 50 milligrams every 6 hours or as a continuous infusion. Steroids accelerate shock reversal and may reduce mortality in selected patients. Do not give steroids for sepsis without shock. Do not delay steroids waiting for a cosintropin test. The board trap is for getting steroids in the patient who remains hypotensive on escalating vasopressors. Peripheral pressors matter because central access takes time. A good proximal peripheral IV can safely bridge norepinephrine when shock is killing the patient now. Avoid tiny distal hand IVs when possible. Label the line, monitor the site, and communicate. The board concept is simple. No central line yet should not mean no vasopressor yet. Source control is resuscitation. Antibiotics do not drain pus. They do not remove an infected line. They do not decompress an obstructed infected kidney. They do not fix necrotizing soft tissue infection. If the source needs a procedure, call early. A common board trap is giving antibiotics and fluids while missing the source that actually needs control. Lactate is a perfusion marker, not the disease. The resuscitation target is lactate clearance, defined as a decrease of at least 10% per hour or normalization. But lactate is not the only endpoint. Reassess mental status, skin perfusion, capillary refill, urine output, mean arterial pressure, and lung exam. The peripheral perfusion exam, including capillary refill time, is increasingly recognized as a useful resuscitation endpoint and may be equivalent to lactate-guided strategies in some studies. The board principle is multi-endpoint reassessment. Treating a single number leads to over-resuscitation or under-resuscitation. Lactate elevation is not specific to sepsis. The classic distractors are beta-2 agonists like albuterol and epinephrine, metformin, recent seizure, post-arrest, and liver failure. If the STEM hands you a normotensive asthmatic with a lactate of 4 after stacked albuterol nebs, the answer is not sepsis. It is beta-2 driven lactate. Cardiogenic shock is hypotension with hypoperfusion from primary pump failure. The most common cause is large acute myocardial infarction, especially anterior STEMI with significant left ventricular dysfunction. Mechanical complications such as papillary muscle rupture, ventricular septal defect, and free wall rupture also produce cardiogenic shock and require surgical or interventional rescue. Management is cautious fluids because over-resuscitation worsens pulmonary edema. Norepinephrine is the preferred vasopressor for hypotension. Adding dobutamine provides inotropic support but can lower blood pressure. Reperfusion for STEMI is critical, and early discussion of mechanical circulatory support, such as intra-aortic balloon pump, Impella, or veno-arterial extracorporeal membrane oxygenation, can be life-saving in the right patient. Bedside echo is essential for identifying the mechanism. Obstructive shock is mechanical interference with cardiac filling or output. 3 causes dominate. Massive pulmonary embolism presents with hypotension, dyspnea, right ventricular strain on echo, and hypoxia. Treatment is anticoagulation with systemic thrombolysis or catheter-directed therapy for hemodynamic instability and pulmonary embolism response team escalation when available. Cardiac tamponade presents with hypotension, jugular venous distension, muffled heart sounds, and a pericardial effusion with diastolic right-sided collapse on echo. Treatment is pericardiocentesis, fluids by time. Tension pneumothorax presents with hypotension, hypoxia, decreased breath sounds, and tracheal deviation in late presentations. Treatment is immediate needle decompression at the second intercostal space midclavicular line or the 4th to 5th intercostal space anterior axillary line, followed by tube thoracostomy. The board concept is that these are mechanical problems requiring mechanical solutions, not vasopressors. Hemorrhagic shock is hypovolemic shock from blood loss, and the treatment is blood. The classes of hemorrhagic shock are based on percentage of blood volume lost. Class 1 is up to 15%, Class 2 is 15 to 30%, Class 3 is 30 to 40%, and Class 4 is greater than 40%. Tachycardia and narrowed pulse pressure precede frank hypotension. The resuscitation is balanced transfusion with packed red blood cells, fresh frozen plasma, and platelets in a 1:1:1 ratio, activated through the massive transfusion protocol when indicated. Tranexamic acid, 1 gram intravenously within 3 hours of injury improves trauma mortality. Permissive hypotension, with a target systolic of 80 to 90, is appropriate for many penetrating trauma patients without head injury. Stop the bleed with direct pressure, tourniquets, surgical intervention, interventional radiology, or endoscopic control for gastrointestinal bleeding. The board principle is that crystalloid for hemorrhagic shock is bridging only. Definitive resuscitation is blood and bleeding control. Not every hot hypotensive patient is septic shock, and not every septic appearing patient is purely septic. Anaphylaxis needs epinephrine. The next step is intramuscular epinephrine into the lateral thigh, 0.3 to 0.5 milligrams, before any IV fluids or antihistamines. Massive pulmonary embolism needs anticoagulation, thrombolysis, or pulmonary embolism response team escalation. Cardiogenic shock needs pump support and reperfusion, and the STEM clues are low ejection fraction, jugular venous distension, and pulmonary edema. Hemorrhage needs blood and bleeding control. Adrenal crisis needs hydrocortisone. Keep the differential alive. Special populations change the threshold for reassessment. End-stage renal disease and heart failure patients may need smaller boluses and earlier pressors. Immunocompromised patients may not mount fever. Elderly patients may present with delirium rather than classic signs. Pregnancy changes positioning, physiology, and consultation. The principle is not to undertreat shock, but to resuscitate intelligently. Boards try to trick you by offering the right diagnosis and the wrong sequence. Do not treat lactate instead of the patient. Do not keep giving fluids when the patient is no longer fluid tolerant. Do not delay norepinephrine for central access. Do not delay antibiotics for CT in a crashing patient. Do not forget stress dose steroids in refractory septic shock, and do not forget source control. The central line is the wrong reason to delay norepinephrine. Case 1. A 58-year-old patient presents with fever, flank pain, confusion, and hypotension. Urinalysis is infected, lactate is elevated, and creatinine is rising. This is not just a urinary tract infection. This is septic shock from a likely obstructed source. Give antibiotics, resuscitate, start norepinephrine if needed, and get urgent decompression. The board trap is treating this like simple pyelonephritis. Case 2. A 72-year-old with pneumonia remains hypotensive after initial fluids. Crackles worsen and oxygen requirement rises. Bedside echo suggests poor left ventricular function. The next step is not endless crystalloid. The next step is norepinephrine, ongoing antibiotics, respiratory support, and intensive care unit admission. The management changes when fluid tolerance is gone. Question 1. A septic shock patient remains hypotensive after initial crystalloid. There is no central line yet. What is the next best step? The answer is to start norepinephrine even through an appropriate peripheral IV while arranging definitive access. The trap is waiting for a central line while the patient remains in shock. Question 2. A patient has fever, flank pain, hypotension, infected urine, and hydronephrosis. After fluids and antibiotics, what changes outcome? The answer is urgent source control with decompression. The trap is treating an obstructed infected stone like uncomplicated pyelonephritis. Question 3. A patient has elevated lactate, but mentation, blood pressure, skin perfusion, and urine output are improving. What should you do? Reassess perfusion and trend the lactate in context. Lactate matters, but the board trap is treating a number while ignoring the patient. The final takeaways are these. Shock is oxygen delivery failure, not just hypotension. The 4 shock categories are hypovolemic, distributive, cardiogenic, and obstructive, each with category-specific therapy. Point-of-care ultrasound, particularly the rush exam, resolves undifferentiated shock fast. Sepsis recognition is clinical, supported by the qSOFA score, but not defined by it. The Hour 1 sepsis bundle is lactate, cultures, antibiotics, fluids, and pressors. The vasopressor sequence is norepinephrine, then vasopressin, then epinephrine. Stress dose hydrocortisone 200 milligrams per day is for refractory septic shock. Hemorrhagic shock is treated with blood, not saline. Obstructive shock requires mechanical relief. Thrombolysis, pericardiocentesis, or needle decompression. Source control is resuscitation, and fluids require reassessment because responsiveness is not the same as tolerance. More fluid is the wrong answer in shock that has stopped responding. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the Surviving Sepsis Campaign 2021 International Guidelines, the Society of Critical Care Medicine Sepsis 3 Definitions, the American College of Cardiology and American Heart Association Cardiogenic Shock Guidance, and the Advanced Trauma Life Support 10th edition for hemorrhagic shock. Point-of-care ultrasound protocol references include the RUSH protocol literature, local antibiograms, institutional sepsis bundle pathways, and pulmonary embolism response team protocols should guide site-specific decisions.